Well, welcome everyone to the UNC Bronchiectasis and NTM Care and Research Center's World Bronchiectasis webinar. I'm Leanne Daniels, the Clinical Director of the center. We are excited to bring this Q&A session to patients and their family members, so thank you for joining us today. I'd also like to thank the Bronchiectasis and NTM Association and the North Carolina chapter of the NTM and Bronchiectasis Support Group for helping us to publicize this event. Let me thank our panelists for taking the time to bring their expertise to this forum and for being amazing colleagues to work with. And finally, thank you everyone who submitted questions. We had so many that we are extending the webinar to 90 minutes, ending at 3:30. If we have time at the end, we will answer questions that have been submitted into the Q&A. The webinar is being recorded and will be uploaded for viewing with details to follow. I will now turn over the moderator role to Karen Ellis, our nurse coordinator and the nexus of our center.
Thanks, Dr. Daniels. Welcome, everybody. Again, thank you for coming. We had a lot of really great questions submitted, and our panelists range from, of course, pulmonary physicians, respiratory therapists, pharmacy, ENT physicians, thoracic surgical physicians, allergy, immunology, and GI. We also have our dietitian present as well to answer any questions with that. So we will just get started, and I will direct the questions to whom I think would be best suited to answer. So we'll just get started here. Let's see. When was the first case of bronchiectasis diagnosed? And this will be for you, Dr. Despotis, with pulmonary.
Sure. So symptoms of bronchiectasis have been described throughout history, but the first case of bronchiectasis that was diagnosed related to the structural changes of the abnormally dilated airways was back in 1819 by René Laennec through autopsies, and he actually coined the term bronchiectasis or dilated airways from the Greek origins. He's also the inventor of the stethoscope, so he's a big deal in the pulmonary world.
That's awesome. Thank you. All right, next up will be Dr. Olivier with pulmonary. Has this disease been out there for some time, and why was it not addressed until now? Why has it not been important enough to put out there?
I think it's always been important, as Dr. Despotis described. It's been in the medical literature since the early 1800s, and kind of taking history quickly forward from that, Sir William Osler at Johns Hopkins did quite a bit of work clinically on describing the disease further. I think it really depends worldwide on what your focus has been. If you talk to countries where tuberculosis has been very prevalent, they've been aware of bronchiectasis, and it's been out there for many years as a complication of that disease. In the US, at least my initial awareness of it was through the genetic disease cystic fibrosis, and I think that the Cystic Fibrosis Foundation put a lot of money into research in this area. And I think as the disease has evolved and we've understood more about the many different associated conditions and causes of it, awareness has increased. But I think what has really led to increased awareness recently is having new therapies available to treat it. Interest from the pharmaceutical industry greatly enhances advertising and outreach and education. And I think you're seeing the fruits of interest in drug discovery for the disease.
Excellent, thank you. Dr. Jakaria with pulmonary, what is the difference between COPD and bronchiectasis? If I have bronchiectasis, does it follow that I have COPD?
That's a great question. I'll simply start by saying no, bronchiectasis and COPD are not the same disease. They're both lung conditions. They can happen sometimes together in the same person, but one does not automatically mean that the other has to be present. In simple terms, COPD usually means that the airways are narrowed and damaged from usually smoking or long-term exposures, whereas bronchiectasis, on the other hand, is abnormally widened airways, where mucus gets trapped and infections happen more commonly. Symptoms, both of them do have some overlap with, cough, mucus, shortness of breath. But the underlying reason why they develop is usually very, very different. So if someone has bronchiectasis, it does not really mean that they have COPD. But somebody who has COPD, usually from smoking, could eventually develop bronchiectasis in future. And just to think about it, in the past, bronchiectasis was, as I said, thought to be a smoking related disease. But we now know that bronchiectasis is a very distinct disease with its own causes, its own evaluation, its own treatment. That's one big reason why the Bronchiectasis and the NTM Foundation sort of emerged as a spin-off of the COPD Foundation to help make bronchiectasis and NTM sort of more recognized and separate from the other underlying conditions and not just a part of COPD.
Okay, thank you. Okay, next we'll go to Dr. Schwar with Allergy and Immunology. Please explain the immunoglobulins and subclasses and why this blood work is checked.
All right, thank you. This is a complicated question, and as the immune system is quite a complex system, but basically immunoglobulins, also known as antibodies, are proteins in the body that fight off infections. And so antibodies are important to protect the body against different types of infections, both viruses, but especially bacteria. And if your body doesn't make enough antibodies, or if your antibodies don't work properly, then this makes you more likely to have infections, makes the infections last longer, and makes the infections potentially more severe or serious. And in patients with bronchiectasis, this can be particularly problematic. So as part of the evaluation for bronchiectasis, we'll check the antibody levels, which we'll call quantitative immunoglobulins, and also immunoglobulin subclasses. So the immunoglobulins or antibody levels are broken down into IgG, which is the most abundant antibody in the blood, IgA, which is something on the mucosal surfaces, including in the lungs and in the nasal surfaces, and then IgM, which is the first antibody made. The IgG subclasses are subsets of the IgG antibodies that have specific roles in fighting off different bacteria. And then we'll also check the antibody levels in response to vaccination that tells us how well your body has made a response to the tetanus or the pneumonia vaccines. And overall, this workup tells us if someone is able to mount an antibody response that could be important to fight off infections. This is important to know because if the antibody response is not normal, it might change sort of how we think about the bronchiectasis in general, and also talking about things like prophylactic antibiotics or replacement antibody that can be used for treatment.
Great. Don't go anywhere. The next one's for you, as well as Dr. Aurora with GI. Does bronchiectasis exacerbate other chronic conditions such as rheumatoid arthritis or inflammatory bowel disease and vice versa?
Yeah, I can take it first just briefly for rheumatoid arthritis. So rheumatoid arthritis, yes, is the short answer. There's both data to support that it can exacerbate, the bronchiectasis and rheumatoid arthritis can exacerbate and play a role in each other's pathogenesis, but the overall interaction is not completely understood. There are ideas that autoantibodies involved in the early development of rheumatoid arthritis can start in the lungs, so there is a link there. The inflammation that's associated with rheumatoid arthritis is associated with worse symptoms of bronchiectasis or worse bronchiectasis. And finally, medications used to treat rheumatoid arthritis, such as biologics that kind of lower the inflammatory cytokine response, can predispose people with bronchiectasis to infection, including mycobacterial infections.
And actually, it's pretty similar on the GI side. So when it comes to inflammatory bowel disease, we don't quite have enough data to understand how strong the connection is between the two, but we do feel like there is a potential connection. Our treatments can also put you at a slightly higher risk for infections if you have bronchiectasis. So it's pretty parallel to rheumatoid arthritis. I think there is more studies that are being done to better understand, especially in ulcerative colitis, which was one of the two main types of inflammatory bowel disease, because it feels like there may be a stronger connection there, but more to come.
Great, thank you. This next question has a few different folks that we might need to hear from. We'll start with probably Dr. Kemple with ENT, maybe even Dr. Schwar again with allergy, and Dr. Aurora with GI. Please discuss the difference between throat and lung mucus. I have bronchiectasis, and it seems as though 90% of the mucus that I have is from my throat. Even after an hour treatment with my nebulizer, 7% sodium chloride solution, and the vest, the greater majority of my mucus comes from my throat. I can't get to the bottom of it. I cough up mucus all day and into the night from my throat. I'm not aware of any allergies, and I don't think I have postnasal drip.
That's a great question. And I think a lot of patients experience a lot of mucus in their throat. And part of that is really that all of our mucus eventually makes it to our throat before we can kind of expectorate it or swallow it back down. So we're either spitting it out or we're swallowing it back into our stomach. And I think one of the reasons it's hard to kind of figure out where it's coming from is because the little cilia in your airways kind of bring it from your lungs into your throat intentionally. Your nose or your nasal cilia move mucus from the front of your nose to the back into your throat. And generally, a human makes about 1 liter to 1.5 liters of mucus just in their nose a day. And so it's constantly kind of pouring down the back in a thin layer, going to our throat, and then we generally swallow it. I think the GI contribution, when I discuss with patients, is that small amounts of reflux will also kind of really irritate the throat. The lining of our kind of food tube or the esophagus is supposed to feel acid, but when it makes it into your nose or kind of the back of your tongue, specifically like the lingual tonsils, you get lots of extra kind of mucus production and the sensation that that tissue is swollen. And then to complicate things even more, there's a psychological component where it feels good to clear your throat and try to cough it up, but that's very irritating to your voice box. It's very irritating to your pharynx. And so that in and of itself kind of makes more mucus as well in a vicious cycle. And so when I see patients with this complaint, which is very common, I say we're going to try to optimize all the things we can and see how it works, but it's a complex problem. And Karen alluded to that by just saying that Dr. Kimple, Dr. Shore, and Dr. Aurora all might be kind of chiming in. And Dr. Chikaria as well could be chiming in from the pulmonary standpoint. And so it's a complex question, but all the mucus pools in our throat before we clear it.
Great. Anything to add, Dr. Shore or Aurora?
I think Dr. Kimple really covered it quite well. The only thing I would add from the GI side is that we feel like we're one piece of that bigger pie, and we're just trying. And so usually what we'll do is we will, as Dr. Kimple mentioned, try to optimize. So we'll try to reduce the amount of reflux that may be coming up from the stomach into the esophagus and the back of the throat to reduce that irritability. And so there are some medications that can help with that. There is also some testing that we can do to help figure out, well, how much of this may be from reflux. But over time, what's interesting is that that cycle can actually make the symptoms much worse, even if the amount, let's say reflux is driving it, even if the amount of reflux stays the same, there is that sensitivity that happens over time that can continue to cause the symptoms to progress.
And I would just echo the same thing. I mean, I think Dr. Kimple and Dr. Aurora kind of put it well. I think the same thing with the GI reflux is true with the postnasal drip. It doesn't have to be driven by allergies, and people may not sense this postnasal drip, even if there is perhaps more than there is in somebody who doesn't have nasal or bronchiectasis disease.
Great, thank you. That's a really awesome segue to our following two questions, specifically for Dr. Aurora. What are some signs I should look for that suggest silent reflux, and do I need testing?
That's a great question. It's something that comes up quite a bit. To take a step back, when we think about reflux, so everybody has some amount of reflux that happens throughout the day, especially after we eat. What makes it a disease is normally when we have symptoms, and the two classic symptoms are heartburn and regurgitation, which is that free flow of food particles or liquid kind of up into the back of our throat. The idea or concept of silent reflux is there damage happening that I may not be feeling? When it comes to some of my pulmonary patients, one of the things we may watch for is a change in their pulmonary function that may not be otherwise explained. And in those cases, we may dig into it a little bit deeper to see, are there some mild symptoms, and is it worth doing testing to better understand, or should we work to optimize treatment to help reduce, again, that kind of burden of that reflux coming up? Some of the testing that can be done is there is testing called pH testing, which allows us actually over 24 hours to see how much reflux someone produces, and if it's acidic or non-acidic, and how high it comes up, which is kind of can help us better understand, is it playing a role, and if so, how much?
Great. If I cough after eating and drinking, does that mean I have trouble swallowing or that I have reflux?
Great question. So cough is actually quite complex. And when we think about it from the GI side, if you're having coughing while you're eating, what we think about is actually the muscles of the mouth and the throat, and are they coordinating well to help you to take what you're trying to eat and push it back into the esophagus. And if there's residue, sometimes that can trigger a cough. Sometimes if there is issues with the muscle function of the esophagus and you're not able to actually push that food down or have peristalsis of the esophagus in an effective way, that too can lead to coughing. And then lastly, you can actually also have coughing after meals if there is reflux that's coming up into the higher parts of the esophagus or into the back of the throat. There are ways to kind of separate that out and tease out what may be going on. And a lot of times it does involve thinking about the timing of the symptoms, how you respond to, say, acid suppressing medications, and then further testing like the pH testing or actually upper endoscopy to actually take a look to see if there is damage from the reflux that may guide us as to what may be going on.
Okay, thank you. Our next question will be for Dr. Olivier with pulmonary. I often have yeast or mold grow from my cultures. Is this a problem?
This is a common occurrence. We did a small study at the NIH a number of years ago looking to see how many different types of yeast or mold patients had over time, and some of them had up to 16 different varieties. These are common in our environment. Yeast is part of the normal sort of flora, microbial flora in the mouth. And so having yeast on a sputum culture is not uncommon, and it generally has no clinical significance. Only in patients who are severely immune compromised, particularly those on high doses of steroids for prolonged periods of time, can rarely have involvement of the lower airway. The molds are a bit different, and the most common mold that we see is Aspergillus. This is the common household mold. Most of the time when we see it there, it is likely either transiently passing through our respiratory tract or a contaminant. If we see it recovered repeatedly on sputum specimens, or if the lab reports it out in high amounts, or if the patients have some form of immune compromise, that generally becomes more concerning, and we may consider treatment or looking into other causes. Sometimes the mold can cause an allergy that Dr. Schwar knows about that is treated very differently than if it's an invasive infection. But I say for the majority of the time, the molds that are there occasionally don't have clinical significance that we know of.
Great, thank you. I know I get that question a lot, and it seems like there's a fair amount of nuance to the answer, so thank you. All right, next question I think I'll take. The question is, when the lab tests for acid-fast bacilli, or AFB, come back with a 3+ designation, what does that really mean to the patient? Are there a range of numbers? Is 3+ high? So it's a really good question. And So when we test your sputum for AFB, we're testing, it's a kind of a two-part test. And the first part comes back, it's an AFB smear. And what this is, it's a super quick glance to see if AFB are readily present. It can be a good indicator of the amount or burden of the mycobacteria in the lungs. It also depends on the specimen quality as well. But the range of the results can go from no AFB present on the smear all the way up to 4+, which would be a higher burden of AFB found. So in some labs reported out not in numerical designation, but rather few, moderate, or heavy. So it is possible to have a negative AFB smear, but still a positive AFB culture. And the reason for that is that it's very slow growing, and it takes it to sit in the lab for upwards of 6 weeks to know that final answer. After added that. Yeah.
Karen, I think you were breaking up just a little bit.
Oh no, like the whole thing?
No,
Just the
no,
end.
just the very end.
So if you directed a question to somebody, if you wouldn't mind repeating that. Right.
Oh yeah. Well, I don't know what part y'all stopped hearing me. But basically, the smear is a quick glance to see if AFB are present. It can be reported as no AFB all the way up to 4+, which would indicate a higher burden. Some labs report them out as like few, moderate, or heavy, as opposed to the numbers. And I did say that it's possible to have a negative smear, yet a positive culture. And that's because it's very slow growing, so it has to sit in the lab for upwards of 6 weeks. So hence the long wait. And I was wondering if there was anything y'all would add to that answer.
I think that's a great response to that question. I would just mention that if the smear is negative, that tells us a little bit about the quantity if the culture is then positive, because it takes a fair amount of organisms for the microbiologist to be able to see it under a scope. So we use that to kind of give a rough estimate of how much of it is down there. Great answer.
Great, thank you. All right. Next question. It looks like it will be for Dr. Jakaria and maybe Dr. Schwarr as well. When a lab test reports indicates Aspergillus fumigatus light along with Mycobacterium avium, is Aspergillus fumigatus a clinical concern? And is Aspergillus treated with oral medications? Dr. Jakaria, you first.
That's a great question. I'll say a short answer. It can be a concern, but not every positive test means that it is an infection that needs treatment. And we heard a little bit earlier from Dr. Olivier. A lab report of Aspergillus could mean many different things. Colonization, where the fungus is just present, not really causing disease, or a true infection, or in some cases, and we'll hear shortly about ABP or allergic bronchopulmonary aspergillosis. What we really look for, or what tells us that it really matters, is patient symptoms, which have to progressively show us that there is active infection. CT scan findings, there are some very specific CT scan features of Aspergillus infection in the lungs. Whether the fungus is found repeatedly, and we really exactly why we need those repeated cultures showing the same organism again and again. And if there is a history of mold exposure, that also really helps. So the result is not just interpreted by the lab report alone. It has to match the clinical features and the history of the patient, whether they are immunocompromised, which makes it even more likely that they could be developing an invasive fungal infection. And then to your second question, is it treated with oral medications? Yes, when you treat it, sometimes we do use oral antifungal medications. You may have heard medications such as voriconazole or posaconazole. Those are usually used. We have excellent pharmacists on our team who help us for dosing those medications as well, because they need monitoring. They need a lot of labs that need to be monitored more frequently. So, in short, finding Aspergillus on a report automatically does not mean disease. Uh, we have to look at many different things, patient symptoms, repeated cultures, and then allergy testing as well that we'll hear from very shortly.
Yeah. Thanks, Dr. Jakaria. And in terms of allergy to aspergillus, so allergic bronchopulmonary aspergillosis or ABPA, is an allergic and inflammatory response to the aspergillus or other types of mold fungi. And this also requires some clinical and laboratory clues to tell us that this is going on. There's typically a lot of mucus production. And again, if you're looking at this in someone who has bronchiectasis, there are typical imaging findings on CT scan that can lead us in this direction. But to look at the allergic inflammation, we'll check the amount, we'll check and see if someone has IgE or the allergy antibodies that they're actually sensitized to the Aspergillus mold to make an allergic response. We'll look at the total amount of the allergy antibodies. So this is an important lab test to really tell us if this is ABPA. And then some other tests on the blood count, such as the eosinophil is also done, and some other immune testing towards the Aspergillus itself to tell us if you're sensitized and if you have the right type of immune response that tells us this is ABPA. And the same thing is also true. The treatment for ABPA is typically with an oral antifungal medicine and with oral steroids. There are some newer treatments with injectable monoclonal antibodies that are being used more often, but have not yet been FDA approved for treatment of ABPA.
Great, thank you. Next question will go to our respiratory therapist, Priscilla. Is distilled water free from MAC or Mycobacterium avium complex? I distill my own water. My research often conflicts.
So we do not recommend purchasing distilled water from the store because that's not going to be free of everything. So we don't recommend that you buy that. When you're distilling water, you are sterilizing it, but you're also removing the minerals, which is why they recommend using it for a lot of equipment because then you're not leaving deposits on your equipment. However, boiling it is perfectly fine to sterilize it. Once you bring it to a full rolling boil for 5 minutes, it is sterile water. And then you can use that for whatever cleaning you want to do. However, you cannot just sterilize it and leave it sitting around because then it just gets bacteria. So you have to use it right away. So you can't really make water to use later. They do sell like medical grade sterile water that you could purchase if you wanted to do that. I would think the process of distilling water at home might be a little onerous and maybe just boiling it might be better.
Okay, thank you. Dr. Kimple, do sinus cultures mirror the lung bacteria?
That's a great question as well. And I think the short answer is generally most of the time. So probably the best data on this literature comes from cystic fibrosis. And generally we see kind of the same genus and species and even kind of genetic strains of Pseudomonas in the noses and the lungs. And in some cohorts actually out of Duke, there have been some studies looking at transplanted lungs, and the Pseudomonas that ends up infecting their lungs ends up being the Pseudomonas that was in their nose prior to the transplant. So we do think there's a direct relationship. It's not a perfect correlation where everything in your nose ends up in your lungs, but there are definitely kind of higher rates of what you have in your nose will end up in your lungs as well for most bacteria.
Okay, thank you. Priscilla with respiratory therapy, back to you. Should I be using my inhaler every day before nebulizing saline or after?
Well, different patients have different kinds of inhalers. If you're referring to what is often called a rescue inhaler, which is going to be albuterol or Zopanex levoalbuterol. If you're going to use that, you can use it before you nebulize. That's the appropriate time to use it. If you have other inhaled medication, we recommend doing that after your airway clearance. So all the other inhalers that you might be on should be used after your airway clearance.
Great, thank you. Dr. Daniels, brensocatib or BRINSUPRI is associated with less lung decline. How is less lung decline measured clinically in bronchiectasis?
Well, in the Aspen trial, which was the phase 3 trial of brensocatib, FEV1 was a secondary outcome, with the primary outcome being exacerbations. FEV1 is the amount of air that you exhale in that first second of your pulmonary function testing. In the study, in the placebo groups who got no drug, there was a loss of about 62 milliliters in that FEV1 measurement over the course of a year. The 10 milligram group had a loss of 50 milligrams or 50 milliliters, while the 25 milligram group had like 50% less loss, so 24 milliliters. And so, to put in perspective, a healthy non-smoker will lose about 20 to 35 milliliters of their FEV1 every year. And so the goal of brensocatib is not necessarily to immediately improve the FEV1, but rather if we've reduced the exacerbations and this neutrophil, this white blood cell mediated airway injury, we slow the rate of FEV1 decline and move the patient closer to a normal age-related decline of about 20 to 35 milliliters a year rather than accelerated progression. Now, in the study, they also used validated quality of life questionnaires such as the St. George Respiratory Questionnaire and the Quality of Life Bronchiectasis, which measure symptoms such as cough, speed and production, breathlessness, fatigue, and daily function. And we saw a significant improvement in quality of life with those who were on brensocatib. And this is important because some patients will have symptoms that worsen over time, even as their lung function remains stable.
Great, thank you. We'll stay on topic of this drug for just a moment. Morgan, a couple of questions for you with pharmacy, excuse me. Is brensocatib, excuse me, or BRINSUPRI the only medicine that they have come up with to help treat us?
Good question. BRINSUPRI is an exciting new treatment for bronchiectasis, but it's definitely not the only medication that we have. Bronchiectasis is very much individualized to different people because you have different causes of symptoms and different types of infections. So for people that may have frequent flare-ups or exacerbations, medicines like azithromycin can help to reduce the number of flare-ups that you might experience. But if somebody has a lot of chronic infections like Pseudomonas, we may use inhaled therapies like tobramycin to help control the infection. And we also have our airway clearance therapies that you heard Priscilla refer to. Those maintain a very important status to help clear the mucus from your lungs. So BRINSUPRI adds another tool to our toolbox, but it's working with the antibiotics to help reduce the inflammation that can contribute to the lung damage and flare-up. And then I would also just plug, if patients are considering or interested in clinical trials, I would encourage you to explore those if you're eligible. Many of the treatments that we do have today, including BRINSUPRI or brensocatib, became available because patients volunteered in research. So clinical trials can be one of the best ways that we can continue to develop better treatments for bronchiectasis.
Yeah, great. And Morgan, to really go along with that answer, you had mentioned, inhaled tobramycin for treatment of Pseudomonas, and one patient wrote in that they have been feeling that as long as you mix the tobramycin with the BRINSUPRI, I'm assuming they mean taking them simultaneously, that the flare-ups of coughing are not as frequent, but once they stop 1 to 2 weeks later, I'm assuming once they cycle off the tobramycin, the coughing fits come back. And they're wondering if maybe they should just be on it simultaneously always.
good question. And I'll preface it by saying definitely discuss this with your healthcare team if you haven't already, because I think for each individual, the situation is going to look a little bit different. So keeping in mind, we mentioned this briefly, but the two medications have two different jobs. So the tobramycin is an antibiotic that's going to be used to treat that bacteria like Pseudomonas, whereas brensocatib or Brinsupri works to reduce the inflammation that's contributing to your flare-ups, but it's not going to treat bacterial infections. So if you have a chronic Pseudomonas infection, you may still need the inhaled tobramycin even after you've started Brinsupri. But we may have patients who don't need to stay on their inhaled antibiotics long term. So this is why it's super important to talk to your care team, because they're going to be the ones that can look at your sputum cultures, your symptoms, your lung function, and how often you're having flare-ups to determine if you need one or both medications.
Great, thank you. Okay, going on to Priscilla with respiratory therapy. Does the use of a nebulizer with 7% sodium chloride disturb sleep if used in the evening?
Using the 7% or 3% or whatever any airway clearance that you do, generally a lot of patients find, especially initially when they start doing airway clearance and they have a lot of mucus, that if they do the airway clearance close to bedtime, when they lay down, any mucus that has been loosened up that they haven't already coughed up starts kind of draining into their larger airways, which causes them to cough and be up late at night. So generally, we would recommend that you do your airway clearance a little earlier than close to bedtime. And if you find that when you lay down, you still have a lot of that coughing when you go to bed at night, I will often recommend that in the evening after you've done your airway clearance, that maybe you lean back in a recliner or something after you've finished it, and whatever mucus has loosened up will drain then, and you can cough it up, and that will help you sleep a little bit better.
Great, thank you. Another question for you, Priscilla. How often should I clean my spacer, and how do I do that effectively?
So the spacers that we provide in clinic cannot be heat sterilized. And although we recommend that you sterilize all your nebulizer equipment and any aerobicas or anything like that that you use, you cannot sterilize these. Generally, when you use it, I recommend exhaling into the air instead of exhaling through the spacer. Even though the directions in the spacer sometimes say put it to your mouth and exhale into the spacer. If you exhale into the air, you're not breathing all the stuff in your lungs into that. And then just initializing the inhaler and breathing it in. You can sterilize them by soaking them in alcohol. Generally once a week is probably often enough to do that. I know many people are very, very diligent about keeping their equipment clean and sterilized. There are spacers available. Pari makes a spacer called Vortex that can be boiled, that if somebody wanted to boil frequently with the rest of their equipment, they could. But otherwise, just soaking your spacer that you have in hot soapy water once a week it should be fine, as long as you're not breathing into your spacer.
Thanks for those tips. Okay, next is for Dr. Modi with thoracic surgery. When is resection or surgery reasonable to consider? Why can't we just remove the area of bronchiectasis?
Karen, thank you for the question. So there are some very serious reasons why lung resection or surgery to remove part of the lung is done in people who have bronchiectasis. Those more serious reasons are if there's bleeding, If the cavity develops some fluid that gets infected, we also call it an abscess. Or if there's an abnormal connection from the edge of the cavity to the lining around the chest, you might hear us say something called BPF or bronchopleural fistula. Other reasons why surgery might be considered are if the antibiotics aren't working or if they're not being tolerated, and that can come in different forms. Dr. Daniels and Dr. Olivia are very good at managing those issues. So the follow-up question is, why can't we just remove all the areas of bronchiectasis? Depends on the pattern of the bronchiectasis. Are there more than one area? Would removing one help solve the problem? How strong are the person with the problem in the lungs and the lungs themselves? And then finally, something that Dr. Jakaria mentioned early on, how dilated is the airway? And is it so dilated that it might be difficult for me to cut across it, or for it to heal back up after it's been cut across? So those are the reasons why we might think about surgery, and some of the reasons why we might think about not doing surgery in people who have bronchiectasis in their lungs.
Great. Also for you, Dr. Modi, so what types or what are the different types of lung surgeries, such as a lobectomy versus a wedge versus a segmentectomy?
That's also a very good question. I wish I had a picture, but if you were to listen to the names, in some ways that helps. Wedge is like taking out a small piece of pie, a little triangle of lung tissue, often removed using staplers in the modern era. A segmentectomy is the next step up. Each lung lobe has a different number of segments in it, and it's like we're going inside the lung lobe and removing a portion of that lobe. Lobectomy means removing, let's say, the whole right upper lobe. There are 3 lung lobes on the right, upper, middle, lower, and means cutting across the blood vessels that go in and out and the airway that goes into that lung lobe. Each surgery can solve problems in different ways and have different amounts of healing time that are required.
Great, thank you. Dr. Daniels. Oh, this is a big one. Why is it important to continue nebulizing when you bring up no sputum?
Well, so airway clearance is a normally occurring process of microscopic pieces of mucus being swept up and out of our lungs. And we only become aware of it when there's sufficient accumulation of mucus that comes up as a glob. And so in bronchiectasis, our normal mucociliary escalator that helps to move that mucus up and out of the lungs is reduced, and the mucus production is increased. Therefore, we have to intentionally augment the airway clearance to ensure that the mucus comes up. I often use the term airway hygiene for airway clearance. Just like dental hygiene or brushing our teeth to keep the tartar from building up, we're using the airway hygiene to keep the mucus from building up. When the mucus builds up in the airways, it makes you cough, short of breath. We're trying to improve that rather than getting you to visibly cough up mucus. I've yet to have a patient request, can you help me to cough up visible mucus? I want to see what's in my lungs. Rather, it's, can you control my cough? And we do that by confining it to times of airway clearance.
Great. Next one is for Dr. Olivier with pulmonary. And I think that this question speaks a lot to the, like I said earlier, the nuance in each individual patient's clinical situation. But there's been a lot of wait and see before prescribing treatment for NTM and Pseudomonas. But I've also recently heard that this may not always be the best approach. That is, if you wait too long, you have a risk of increasing irreparable lung damage. Any insights on this?
Yeah, that's a tough one. I think what some people perceive as wait and see, others might perceive as sort of staged treatment. If you take Pseudomonas, for example, we know that people that harbor Pseudomonas recurringly on positive cultures, those patients are more likely to have exacerbations or flares. They're more likely to have a faster decline in their lung function. But many of these organisms can sort of transiently be in the airway depending on the status of airway clearance. So frequently, if it's the first time that we're isolating it, we'll recommend to patients that if they don't currently have an increase in symptoms, that they increase attention to airway clearance to see if they can sort of optimize the status of the airways and then repeat the culture to see if it's still there. If it's then there repeatedly, there's a concept called eradication, which comes out of the cystic fibrosis literature, where children generally are followed from early on in life with repeated sputum cultures on a regular basis. And it's pretty easy to tell the first time that Pseudomonas is there. And if those children or young adults are treated aggressively for Pseudomonas, it can stay away for a long period of time. And if you can delay that sort of chronic recovery of that organism, that generally results in better preservation of lung function. When bronchiectasis is diagnosed in adulthood, especially as we get a bit wiser, it's really hard to tell how long those organisms have been there, and sometimes that eradication approach doesn't always work. And so if you're having a lot of symptoms and we recover it from your lower airway, we generally will treat that right away. And if not, we'll generally see if that's an isolated occurrence or if it's there repeatedly, and then talk about ways to suppress it. With regard to NTM, it's a bit more nuanced, and I'll just put a plug in for next month is World NTM Day on August 4th, and we're hoping to have a repeat of this so we can go into this in more detail. But as opposed to treatment of Pseudomonas, where that's a relatively short-term treatment, treatment for NTM in general requires multiple drugs over a prolonged period of time. So again, we would like to see airway clearance optimized first to make sure we're repeatedly recovering the same species of mycobacteria, because there are many different ones. And then if so, to start treatment in sort of a stepwise fashion. One other reason we tend not to do that when you first see us is that it is frequently the case where we can overwhelm you with information on a first visit. And so having this as sort of a staged approach and having multiple team members involved with education and facilitating getting started on these drugs and monitoring for side effects is part of our plan and approach.
Okay, thank you. Morgan, our pharmacist, some questions about complementary or alternative medications. Can N-acetylcysteine or NAC help with treatment? And if so, what's the recommended dosage?
Yes, this is a supplement that we get asked about quite often. NAC comes in two formulations, an inhaled or nebulized form and an oral form. The nebulized form acts as a mucus thinner, but it has a very strong sulfur smell. So many people describe it as smelling like rotten eggs. So because we have other effective airway clearance therapies like hypertonic saline, nebulized NAC is not really used for bronchiectasis. The oral formulation has been studied to see if it can reduce inflammation and help prevent flare-ups, but there's not a lot of strong evidence to support its efficacy at this time. So NAC is generally not routinely recommended as part of our standard bronchiectasis treatment. If somebody is interested in trying oral NAC, I would say discuss it with your healthcare team first. It's generally well tolerated, but it can come with potential GI side effects like nausea, vomiting, and diarrhea. But otherwise, generally okay to take and not interacting with a lot of other medications. But again, talk with your healthcare team. And then one thing I'll just say in general about supplements is that they're not regulated as strictly as prescription medications. So this means we don't always know if what they contain is exactly what's stated on the label or how well they will work or whether they could interact with your prescription medications. So if you're interested in taking any supplement, I would encourage you to talk to your provider to make sure that it's safe and won't interfere with any of your other treatments.
Thank you. All right, moving on next to Edward Marcus, our dietitian. Why is nutrition important in bronchiectasis?
Thanks, Karen. So, nutrition matters in bronchiectasis because your body may be working harder than usual to breathe, to clear mucus, and to recover from infections. So, eating enough calories and protein helps protect your muscle and your strength. It can support your immune system, and it gives you the energy that you need for airway clearance and for regular day-to-day activities. Hydration is also important because the fluids can help keep your mucus thinner and easier to clear. There's not one special bronchiectasis diet that works for everyone, and I'd be really cautious about any claim that one specific food or supplement treats bronchiectasis broadly. But for most people, the focus is on maintaining a healthy weight, preventing unintentional weight loss, getting enough protein and calories, and individualizing the plan around symptoms like poor appetite, reflux, GI side effects from antibiotics, vitamin D deficiency, or weight changes. And I'll also say the good news is that nutrition is one of the supportive pieces of care that we can really personalize. So we're not trying to give everyone the same plan. We're just trying to help each person stay strong, recover well, and make eating manageable. So definitely recommend if you have any questions, you reach out to your healthcare team to discuss what options might be best for you.
Hey, thank you. Okay, let's see. Next is for the next two actually, for Dr. Despotis with pulmonary. Is bronchiectasis a lifelong condition or can it go away? And I think maybe answered this one first. Does age of onset or diagnosis impact disease outcome?
So answering the second question first, you were suggesting?
Yeah,
Okay, perfect.
I
No.
make it easy.
Sure. Age of onset and diagnosis really can impact disease outcomes in a lot of different ways. We certainly see causes of bronchiectasis that are more likely in younger patients, like cystic fibrosis and primary ciliary dyskinesia, because disease onset can happen early on, that in theory, over time, lung disease could become more severe. And so we want to follow those patients very closely in specialized centers. Also, patients who develop immunodeficiencies, some other rare genetic causes. But even beyond the early causes of bronchiectasis, understanding the cause of bronchiectasis can be really important because we might be able to then intervene in different ways. So for cystic fibrosis, we have these modulator therapies now that can be very effective, and starting those early on, even before children have structural changes like bronchiectasis, might help prevent lung function decline over time. Similarly, close attention to kind of growth and nutrition as the lung is growing, and kind of early causes of bronchiectasis like primary ciliary dyskinesia can be really important. And then for people who have immunodeficiencies, either early in childhood or that develop later in life, Dr. Schroer mentioned how we can boost the immune system in different ways, and that can help prevent severe infections that we think can drive lung function decline and more structural changes. So we always want to try to understand the different causes that could be contributing to bronchiectasis, because those really could impact how we manage bronchiectasis. And regardless of the cause of bronchiectasis, and it's tough because we often realize that some people, we haven't been able to identify a specific cause or know exactly what maybe set this off. If we can identify that you have bronchiectasis, then we can get airway clearance started and help with that airway hygiene that Dr. Daniels alluded to. We can be more attentive to new infections and be more aggressive about antibiotic treatment to kind of help preserve that lung function and prevent that structural damage. And so I think that highlights the importance of the clinical care network centers, is that we can be really paying close attention to things to try to optimize outcomes with bronchiectasis, regardless of the underlying causes. And I think this is especially true as we develop more bronchiectasis specific therapies, such as brensocatib or brinsupri and some of the other treatments that are under investigation. Having access to these therapies might be really important to help long-term disease outcomes in bronchiectasis. So I think that was most of the answer to question 2, as far as diagnosis impacting outcomes, age of onset. As far as if bronchiectasis is a lifelong condition or can it go away, we've discussed that there are certainly genetic causes of bronchiectasis, and those certainly require management throughout the course of someone's life. And again, hopefully early treatment minimizes lung damage, but we think of it typically can occur very early on. We know for some people it doesn't develop until later in life, but once you develop bronchiectasis, we have historically thought of it as irreversible damage that's happened to the lungs that then sort of leads to ongoing symptoms and challenges. However, there are some reports, mostly in the pediatric literature, that some of the imaging findings of bronchiectasis can improve or even resolve if they were, especially if they were mild cases when you've been treating an infection aggressively. And there's some debates as far as why this might be the case. Some think maybe when we're getting that first CT scan where we see dilated airways, which is how we kind of identify bronchiectasis on CT scan, that some of the airway dilation was more related to mucus plugging in the setting of acute illness. And then when imaging is repeated, if that mucus plugging has gotten better, that shape and size of the airway has gotten to be more similar to where it was, has normalized more. There's also likely a component of some ongoing lung growth and development, and maybe more potential for remodeling in children with bronchiectasis that might not be as likely to be as active in adults with bronchiectasis. But this is certainly an area where there's a lot of interest, because if we could do more things to reverse those changes, I think that would be really beneficial for a lot of people. So I think overall, though, it's still why we want to be aggressive in our airway clearance and treatment of infections to improve things that might be able to be improved at an earlier stage.
Great, thank you. And Dr. Olivier, with pulmonary, I think Dr. Despotis touched or alluded, but do people tend to get worse or better as they age?
Well, pertaining to bronchiectasis, as Dr. Daniels mentioned earlier, once we get past 25, it's kind of all downhill in terms of lung function. So we're all losing lung function at a predictable rate, and certainly there are things that can speed that up or not. When you look at a population basis in terms of who gets diagnosed with bronchiectasis in the United States, there's almost an exponential increase in those diagnoses with age, with the vast majority of people in the US with bronchiectasis being in their 50s, 60s, 70s, and older. Whether that's because the disease onset is later in life, or there may be subtle progression of changes that then result in people presenting for diagnosis is unknown. But I would say that the disease course can be quite variable, and it really depends in part on approach to treatment. So I think patients who exercise regularly, adhere to airway clearance measures, act early on infections and get those treated, there may be opportunities to better preserve lung function over time and not have as rapid of a loss. It may also depend on research. As Dr. Morgan Jones pointed out, we are an active research center. We're looking for better ways to treat this. If you use cystic fibrosis as an example, that sort of rapid decline in lung function that was thought to be characteristic of that disease has all changed with these effective drugs called CFTR modulators. And so that really can arrest the progression or a lot of the progression of the disease. And I think the potential for discovery of drugs that can do that for other forms of bronchiectasis is there as well. And I think the answer is in research and bringing new and better drugs to the market.
Okay, thank you. Dr. Daniels, if a person has been diagnosed with bronchiectasis but does not have a productive cough, is the prognosis the same as for an individual who does have a productive cough?
I would say is that prognosis really depends on many factors beyond simply sputum production alone. A chronic productive cough will often reflect higher mucus retention within the airways, a higher bacterial burden, and more inflammation within the lung, which then leads to that increased risk of infection and exacerbations. And we do often use sputum purulence as a characteristic in some of our clinical trials, trying to capture patients who do have more infection and inflammation in their lungs, as this would portend lower lung function, worse quality of life, and potential for hospitalization. Um, if someone is with bronchiectasis makes little to no sputum, is that because they are clearing it at the same rate they're making it, they're at equilibrium. Only a small area of the lung is affected, that they have no chronic airway infections or they have few exacerbations. Well, if in that case, they would generally have a better outcome than someone who is extensively and chronically infected. But I feel some important exceptions that perhaps, despite having significant disease, they're not bringing up sputum because that area doesn't drain well, or the patient's cough is weak and or ineffective at mobilizing their mucus. The mucus is retained deep in the lungs. And then what if it's a dry, sort of fibrotic, some of our interstitial lung disease patients, it's a different process there. And so in general, we use other factors to predict prognosis a bit more strongly. And we do have some scoring systems that have been validated. So the Bronchiectasis Severity Index and the FACID score, they are looking at the extent of bronchiectasis on imaging, chronic infections, particularly Pseudomonas, frequency of exacerbations, lung function, age, other medical conditions, nutritional status, body weight, and then obviously respiratory failure, low oxygen levels. Neither one of the scoring systems actually use sputum production alone as a primary determinant of prognosis.
Okay, great. Dr. Jakaria, can you please explain how important it is to track pulmonary hypertension in bronchiectasis patients and what effect it has on the disease?
That's a great question to think about. So first of all, what is pulmonary hypertension, right? So it really means having a high blood pressure in your blood vessels of your lungs. And why is it important to look for it? Because if not treated over time, it can make your existing breathing symptoms worse and also put extra strain on the heart that can fail the heart in long-term patients. So I am especially alert for pulmonary hypertension usually when bronchiectasis is happening along with another lung disease, such as COPD, because that's when we mostly see it in combination within a long-standing COPD patient who's just not doing well over time. And I'm very well aware that pulmonary hypertension can occur at that same time for that patient. So what symptoms do I really, want to look for? More shortness of breath than the expected, getting very tired easily, reduced exercise tolerance, lightheadedness, dizziness, some chest pressure, chest discomfort, swelling of the legs, which are a combination of sort of heart disease and lung disease symptoms. And then at that point, we start thinking about getting an echocardiogram as our first test to look for early signs of pulmonary hypertension. And if symptoms or tests are suggestive of it, then we would sort of think about getting more advanced testing, which is a little more invasive, getting a catheter into your neck and into your heart with specialized doctors who practice pulmonary hypertension. So what about bronchiectasis alone, right? So if I think about bronchiectasis alone, I don't expect pulmonary hypertension to coexist. The exception if the bronchiectasis is due to a part of a systemic condition, such as an autoimmune condition, sometimes that could also lead to pulmonary hypertension. So in those cases, then my antennae are usually high up and I'm thinking about it more commonly than otherwise.
Great, thank you. Okay, this next question, I believe we'll start with Dr. Kimple, but also open up to anyone on the pulmonary, from the pulmonary group. Can bronchiectasis lead to sinus or head congestion with excess extreme phlegm, causing it to be difficult to eat, sleep, talk? In their particular situation, the cough is continuous and very loud. They're asking for a family member who is losing way too much weight with this situation, and whose energy is very diminished.
So I think I'll start with the last part of that question first. I think if you're having weight loss and kind of energy concerns that don't necessarily have an answer, you definitely need to see your provider. Those are not normal from kind of a well-treated, kind of stable lung disease or sinus disease, especially. I think in the idiopathic bronchiectasis, so if you take away cystic fibrosis and primary ciliary dyskinesia, the literature is very wide in how much of an overlap there is if you have bronchiectasis who has chronic sinus disease. Numbers kind of range from 30 to 65% in the literature of that overlap. And so a lot of people with bronchiectasis have sinus disease, but there's a lot of people who do not. I feel like I see a lot of people from Dr. Daniels and Dr. Jakaria with bronchiectasis who end up not having sinus disease. And so I actually think some of those estimates are probably over exaggerations in the literature, but there are definitely some people who have both diseases. Sinus disease will give you lots of post-nasal drainage. It will decrease your sleep quality. But I would not expect that to kind of result in weight loss specifically. I think that's kind of one of the warning signs for me that we're missing something when people are having weight loss that I can't explain. And sleep quality will be poor, but I would still expect people to be able to sleep. Even if you can't breathe through your night, you can breathe through your nose. You should be able to kind of adequately sleep and oxygenate yourself. And so that's kind of concerning those components of symptoms.
To add on to that, I was going to say it does make me question a little bit in terms of reflux for a patient with that degree of mucus. And certainly saying that echoing what you said, Dr. Kimple, that's a lot of excess calories to be churning up from that. Um, Perhaps you could speak a little bit, even I was going to say, about how sinus disease and nasal congestion might affect someone's sense of smell and how that could impact their appetite.
Yeah, so I think the sinuses and the nasal cavity are kind of where we appreciate our sense of smell. That's where all the smell nerves come into the nose. And as you chew your food, essentially all of those odorants come up into the nose and they give us the flavor of food. I tell patients that their tongue is very boring. It does five things. It does the taste of bitter, sweet, the flavor of protein, salty, and sour, and anything more complex than those five tastes comes from your nose. And so when you do have a stuffy nose or kind of infection in your nose, your sense of taste overall is dramatically diminished. And kind of we call that flavor. Taste should be your tongue, smell should be your nose, but we kind of all use those same words interchangeably. In long-term sinus disease will kind of destroy your sense of smell eventually. Kind of chronic bacterial infections in your nose and chronic inflammation in your nose will kind of destroy the olfactory neurons that come in and they will stop regenerating. And so typically your sense of smell comes back. You take some antibiotics or on some steroids, your sense of smell comes back and that works and works and works until it stops. And that's essentially kind of a neuronal loss from your sense of smell in your nose. Did I answer your question?
Yes, thank you so much. Um, since we do have some time, I have a couple of questions in the Q&A, and I would ask anyone who is still on if there are questions that you have thought of throughout this webinar, please put those in. We'd love to be able to answer them for you. This first one I'm going to direct to Dr. Schwar. Is pneumococcal vaccination recommended for patients with bronchiectasis? If so, which vaccine is recommended? What does it help prevent? And is a booster dose needed?
Yes. So for patients with bronchiectasis, the pneumococcal vaccine is recommended. So the CDC recommends pneumococcal vaccine for anyone over 19 who has a chronic lung disease, which bronchiectasis is one of them. The simplest, it's quite complicated, honestly, the dosing recommend or the vaccine recommendations, and that's a little bit because there are different vaccines that have come out over time. So right now, if you haven't gotten a pneumococcal vaccine before and you have bronchiectasis and you're an adult, you should get the PCV20 or the PCV21. And what these do is they prevent exacerbations of disease that are caused by Streptococcus pneumonia bacterial infection. And they're pretty good at doing that. And importantly, they're very good at preventing invasive infections by the Streptococcus pneumonia bacteria. So they are so for both of those reasons, it's important to be vaccinated. If you have gotten a vaccine in the past, do you need a booster? It depends on what vaccine you got and when you got it. And probably the best thing to do rather than rattle off the many different iterations of this is to just kind of talk to your provider. There's pretty good documents out there on the CDC website, and there's an app that can help you navigate it. But I would, if you've gotten a vaccine before, I would just talk to your provider about when you would need to get another vaccine. And then if you're over age 50 or especially over age 65, you should also talk to them about getting a booster. There's not really clear recommendations about that, but I think it's reasonable to have that conversation at that time.
Excellent. Thank you. Um, so the next question I am happy to answer, but I can also put this to some of my colleagues. What is involved in the first appointment at your care center? How many departments are involved? And is it a multi-day appointment as at National Jewish? So we are not a multi-day appointment. We don't have a place that you could just stay and get everything done. To lead off, we do review every referral. And if we look at it and say, gosh, this person really needs to see Dr. Modi and they're coming from 4 hours away, can we coordinate this on the same day? And we talk about your case together. Um, at your visit, you will meet with all of our core team members. So within the clinic, you will see your physician. You may meet with our pharmacist, Morgan. You will definitely speak with Priscilla for respiratory therapy. Karen will pop her head in, and in general, Edward is there. If we look at your chart and say, gosh, I'm concerned about nutrition for this reason, Edward, we may reach out to Edward and ask him to see you. He also reaches out to all of our patients ahead of their visit. And so if you have questions that maybe we didn't see that sort of flagged Edward as a need to see you, he is always very eager and happy to see you in clinic. Does that answer? I hope that answered the question. If my colleagues have anything to add on to that.
Yeah, Leanne, I would probably just add to, there is an hour that's dedicated for your time with the physician. And then depending upon your clinical needs, the appointment can be pretty lengthy, upwards of 2 hours or so. So just come prepared and just, be expected that it's going to be a very thorough visit. And you'll probably learn a lot during that visit as well.
And Dr. Olivia, I see you answered one of the questions here, but since our attendees can't see it, I was going to put this to you. How would a patient volunteer for clinical trials?
Very good question. We'd be excited to talk to you about that at any time when you are seeing us for your clinic appointment. Make sure you ask us. You can also reach out to us by MyChart with a message. We have research coordinators who help with our clinical trials. We can have one of them get in touch with you. Or if you go to the website go.unc.edu/be.NTM, that will take you to our open clinical trials. So I tried to put that in the chat and that didn't work so well, but
theoretically, it should. I think the link, they were in the middle of flux there. And so I would certainly say is that if that does not work, and if you are not a patient directly within our center itself, part of the invite included Karen's email. And so if you would like to reach out that way, we can pass it to the coordinators. Or if you were seen by another physician within within the pulmonary clinic, please ask them, and they will certainly pass your information to our clinical or our research coordinators to get you to participate. I'm gonna go, let's see, we have a question about with bronchiectasis plus Mycobacterium abscessus, should I wear a mask in A, public, B, family gatherings, or C, garden? Who wants to take it? Ken, Dr. Olivia, I'm gonna pass to you. I know.
I can take that. So, Mycobacterium abscessus in general is not transmitted person to person. There may be some rare exceptions to that, and there's certainly the ability to um, cough it into the environment and have it picked up that way. So I think in general, with chronic infections, wearing a mask could help prevent that. And so in the healthcare settings, that may be something asked of you, but it's not one of the infections that we typically mask for to try to prevent spread person to person directly. With regard to gardening, that's a different topic. That's looking at sort of prevention of acquisition or reacquiring the organisms. And some of the mycobacterium, like Mycobacterium intracellulare, is thought to originate in the soil. And so using a mask might decrease the amount of mycobacteria that you are inhaling when doing activities that might stir that up. The other suggestion that is out there is to wet the soil before you work with it so it's less likely to be aerosol generated. And again, if you are a patient of ours and you're visiting us, we have a standard phrase that we've all reviewed and approved about exposure mitigation. How can you decrease your risk of exposure? There are a lot of things that you can read out there that suggest things that could greatly impede or impair your lifestyle. We've tried to strike a balance in those items, but wearing a mask while gardening can be an effective way of doing that, and also avoiding putting mulch or spreading mulch yourself. And the concern there is mainly from mold transmission.
Thank you. This is a question for Priscilla. Is nebulizing with an aerobica attachment equivalent to huff coughing, or do I need to huff cough in addition to using the aerobica? If so, since I don't produce mucus, how much huff coughing should I do?
Using the aerobica and the nebulizer is not the same as huff coughing. The aerobica and the nebulizer can help loosen up the mucus, and then the huff cough can help you get it out if there is mucus there. Now, if you don't really produce much mucus, just huffing and huffing and huffing is just going to make you dizzy. So the huff cough can help get up, like when you feel like there's a little piece of mucus stuck in there, that can help get it out. But it is not in replace of the airway clearance.
Priscilla, this is another one I'm going to task to you, but anyone can add in. What are the best exercises to do? Is a rowing machine a good exercise? What about weights?
All exercise is good exercise. Exercising is good for your body and your lungs. We generally recommend you get some aerobic type exercise daily, 20 to 30 minutes. I also have noticed that a lot of patients that do yoga find that super helpful to clear their lungs. It's a lot of that deep breathing and positioning can really help sometimes when you have trouble with other kinds of airway clearance.
And we do enjoy or encourage patients to use weights, particularly as a lot of our patients have low bone density, and that's an important intervention that you can do to help improve that. All right, Dr. Jakari, I'm going to pose this one to you. If my symptoms are under control without medication, how often should I see my provider?
That's a great question. I'll say if you like your provider, see them as often as you want. Not just kidding. But point being, I think I would say personally for my patients when there's a complex of other diseases on the side going on, and how uh, much does your primary care provider get the the core of your underlying bronchiectasis disease and is able to understand the progression. If there is enough time and ability, then sometimes after a couple years of stability, we do tell our patients, you know what, everything looks great, and you should be able to pick up on these initial cues and symptoms, and if they were to occur, please let us know right away, or even reach out to your primary care clinician. But otherwise, by and large, if everything is very, very stable, I think once a year at the least is a minimum for a couple years, before which then it can be made as on an as needed basis. As long as we've established the underlying etiology, the cause of the condition, and made sure everything else is stable.
I agree. Well, that was the last question that I had in the Q&A box here. And so unless there are any further questions, and I will even say if our panel wants to ask another panelist a question, you are certainly welcome to. Otherwise, I will say again, thank you to everyone who joined us today. We greatly appreciate your participation, your support. Thank you to all of our panelists. And save the date, Wednesday, August 5th. So it is the day after World NTM Day, but we wanted to make sure we could celebrate. And the 4th, we're in clinic. So we didn't want to disadvantage our patients. That hopefully you can join us then and put forth some specific questions about NTM. So thank you, everyone.
Thank you.